Not all claims had been settled when PhilHealth transferred 60 billion pesos back to the national treasury. This was the admission of the state health insurer during the oral arguments at the Supreme Court yesterday, challenging the constitutionality of the transfer of PhilHealth's excess funds. Associate Justice Ami Lazaro Javier asked PhilHealth Senior Vice President Renato Limsiaco Jr. if all claims had been settled before the funds were sent back to the state coffers. Limsiaco said no because of a certain cut-off date. In the 4-hour hearing, Justice Javier also repeatedly emphasized that PhilHealth's funds should be used exclusively for its purposes and not diverted to unrelated programs. Still, PhilHealth's legal counsel insisted that the state health insurer remains financially sound. Government Corporate Counsel Solomon Hermosura told the SC that over 1 trillion peso worth of liabilities do not amount to an actual debt, but only future obligations based on estimates. The SC will hold their next oral arguments on March 4.
Certainly a lot of issues surrounding the state health insurer lately. Let's dive into this with Dr. Edwin Mercado. He is the newly installed president and CEO of PhilHealth for precisely 22 days now. Good evening. Welcome to The Big Story, Dr. Mercado. Thanks for making time for us.
Good evening, ladies, and also to all your listeners and viewers. Hello, can you hear me?
It's very choppy, Dr. Mercado. Let's try that again. Can you hear me okay?
Can you hear me now?
Yes, we can hear you. We hope it holds.
Yes, I can hear you.
Okay, perfect. It just sounds like there's a little bit of a lag. But let's kick things off. First off, why don't you tell us the story of how you came to this position? How were you chosen to be the new PhilHealth CEO and president?
Candidates that were considered. I think I stood out being a clinician and a hospital administrator, and having been exposed to, as I say, on what it feels to be on the other side of the fence, on the receiving end of what PhilHealth has been doing the past years. I've been operating a hospital chain for the past 27 years until I divested in 2021. So it's a long process, and I think my credentials stood out versus the other candidates, and that's why I was chosen.
I actually missed the first part of your answer, but I'm assuming you said that there were some candidates that were narrowed down. But I know which chain you're talking about. You're talking about Quali Med. But what was your reaction when the position was first offered to you? Is this something that you had wanted from the very start?
I actually applied to the board before, which was last year, to be a sectoral representative of the provider. But I thought that with somebody being appointed as a sectoral representative for the provider, that I'm out of the running. But things happened fast. In a matter of less than a month, things progressed. So I was quite surprised, and I really prayed hard and also asked guidance before I plunged in.
One of the points that was interesting when after you took your oath that you said was that you had been for many, many years on the other side of PhilHealth as a doctor, listening to patients. And just from your experience as a practicing doctor and managing a chain of clinics and healthcare facilities, what would you say are your top 3 biggest things that you feel that you really, really want to change in PhilHealth?
That's a very good question. So first of all, I think I should look at the processes and to make sure that the claims adjudication and the payment are on time. I mean, a lot of our difficulties we feel before is the delayed payment of our claims. Number 2 is the accuracy of the data, because the data right now if you check the hospital's internal data versus PhilHealth data, there are some discrepancies. So our guidance now is one data for both the provider and PhilHealth. And the third issue is the digitalization or the computerization. Because a lot of the inefficiencies and the delayed payment is also due to the automation or the lack of it. Currently, PhilHealth has 69 legacy systems working, and then looking at harmonizing all the 69 systems into a more integrated IT network.
Okay, my next follow-up question would be, now that you have been in office for about 22 days, to be exact, do you feel that these three items on the top of your list, how doable are they? Are they actually doable? And how long do you think before you can actually achieve this? Or if you see some hurdles in your way, please share.
At least the first two objectives, which is the processes and also the single data or financial reporting, is within our control because this is internal. So I'm actually already pushing for a more efficient turnaround time from claims filing to payment. And I was tasked by the board to also look at the process. I actually met with private hospital groups, starting with the big one, a couple of weeks ago, and I asked them for their root cause analysis on why their claims are being denied or returned. And we will align our processes along their root cause analysis so that we are on the same page as regards payment and the payment cycle.
Sorry, speaking of private hospitals, how much is owed to them at this point? Do you know? What is the amount now?
Come again, please. Sorry.
How much is
didn't
owed
get that.
to the private hospital associations at this point by PhilHealth?
It's constantly moving because on a day-per-day, the hospitals continuously file claims and we continuously pay. So I don't have yet the exact figures, but in the next few days, we will be announcing some moves on how to address the backlog and the previously denied claims.
Right. Doc, that's what I was talking about, the backlog, because apparently it goes all the way back to COVID time. And last we spoke to PHAP, which was several months ago, granted, they said, was it 6 billion? That was
6 or 9
it was in the
billion,
billions
somewhere
that PhilHealth still owed them. And I was wondering if you had a more accurate figure at this point in time.
Yes, a lot of these are actually denied due to the lapse of the filing period, because there's an automatic denial if you file beyond the 60-day prescription period. So this we're looking at, because if it's denied just because of the lapse in the filing period and not because of fraud, then we think we should be paying all these denied claims.
And changing those policies, those types of policies, like the timeline, is that really within your power internally, meaning you don't have to consult any other government agency for this, or no need for legislation, etc.?
No, these are all internal policies. So it's all our procedures that can be revised by the board. So it's only a board decision, and it does not need like an enabling law or any approval from any other agency, because it's an internal process that is set by the board, and therefore the board can also make amendments to those processes.
Well, Dr. Mercado, aside from being a physician, you have a wealth of experience as a hospital administrator. I wanted to get your opinion on not having subsidy as a state insurer. How long do you think PhilHealth can last with your current resources without any subsidy from the government?
Currently, we have what you call an actuarial analysis of potential potential revenue and also potential payout of benefits. So with the expected revenues coming in, even if without the subsidy coming for the indirect contributors, there's enough to cover yearly expenses. Obviously, that will change depending on the additional benefits that will roll out. So hopefully by the end of the year, we will have more data and we will be able to maybe present to Congress when the budget season comes in as to how much we need for additional subsidy, which is in fact payment of the premium of the indirect members in subsequent years. And it is in the Universal Healthcare Law that the state, through the intercession of DOH and PhilHealth, can be asked to put or to give supplemental budget to keep the state insurance, the state health insurance afloat.
But Dr. Mercado, I also remember you saying that one of your priorities is to lower out-of-pocket spending of families to 25 to 27% from 45 to 47. But that is a huge leap there. Do you think that's possible within your leadership? How do you intend on doing that, Doctor?
Actually, the lowering of the out-of-pocket expense is not just PhilHealth's job, because the cost of healthcare is not just PhilHealth, but also provided for by the DOH through their budget allocation, and even the local government who also have their local budget allocation, plus the other safety nets provided by like MAIP or Malasakit and the funds coming from the SWD and the PCSO. So it's a whole of nation approach. And I think in the medium term, and this is part of the roadmap presented for the health financing roadmap of the Philippines, is to lower it down to about 30%. So I would like to set a higher target of lowering it down to maybe 25 to 27%. But I think 30% is doable in the short term or in the medium term, which is 3-4 years.
Well, I, for one, can tell you that when you were announced, most of the medical community that we know were pretty happy. We spoke to Dr. Mingita Padilla on our sister program, StoryCon, and she said that most of her peers were happy that you were installed, but there is a big but there. She says it is not enough to replace the president or CEO, that you have to clean up the entire executive the executive committee. How much of a hand or how much of a leeway do you have right now to do that?
We announced internally in the corporation that we're here to bridge and heal, and we're not here to do any witch hunting. But obviously, moving forward, if we set metrics and we will measure the outcomes and the performance of the different members of the whole, not just the ExeCom, but the whole organization, then accountability and meritocracy will be top of my priority.
So for now, the entire ExeCom stays?
Can you come again, please? Sorry.
So for now, the entire executive committee stays? No one is getting reshuffled?
For now, especially to ensure continuity and to also make sure that the programs that have been approved recently is being rolled out properly and efficiently. We're giving marching orders in terms of what should be done in the short term to the existing ExeCom.
And of course, PhilHealth is a fund, and when funds are in question, we talk about actuarial life. I believe in all the brouhaha late last year, coming into this year, some reporters were actually trying to look for the actuarial, the head actuarial of PhilHealth, to try to maybe send some questions. Have you spoken and sat down with the actuarial departments, with the actuaries there, and what did they tell you in terms of actuarial life? How is PhilHealth doing, Doc?
The big issue right now is what you call the insurance contract liability, which is it's not actually a liability that is due and demandable, or in economic or accounting terms, it's a paper loss. So there's a lot of debate as to how to treat the ICL or this future liability of a state health insurance like PhilHealth. It's not the same as a pension fund or a private insurance. and we're even going all the way up to the PIC, which is a branch of the PICPA, which is the body that interprets all these new accounting rules. So we are still waiting for the final sort of definition because, as I said, the state insurance, social health insurance is different from a private health insurance or a pension fund.
And Dr. Mercado, what about wastage? This is something that you also touched on when you assumed office. You did say you wanted to address wastage in PhilHealth. Do you already have an idea on how much wastage the PhilHealth has? And could that be redirected to the expansion, the enhancement of the benefits of members?
Yes, of course, any penny saved or any centavo saved can go towards expanding our benefits. I'm looking at the process and the manpower required on adjudicating cases. Because once you reject a case or denied a claim, then it goes back to the hospital and then it's refiled. So imagine the paperwork, the man hours needed to reprocess and also to re-adjudicate or to look at whether the claims is valid or not. But most of these claims are again, not just the problem, not just to be blamed to PhilHealth, because some are due to improper filing or incomplete filing from the hospitals. That's why we're asking the hospitals to do their root cause analysis, and together we align our processes such that these denied or returned to hospital claims are limited. So just with that back and forth sending the claims, I think if we make it efficient that you don't the claims are complete whenever they are filed, then that's a lot of reduction in terms of man hours and also in terms of cost, especially for your paperwork and also your computer work.
Let me circle back to your other previous answer. You said you have 3 priorities: improve claims and benefits process, improve accuracy of data, and third, digitalization. You didn't give us a sense of how difficult the third priority will be. And I already have a sense because coming back to Dr. Mingita Padilla, she flagged that to us as one of the major issues at PhilHealth. She said you need to digitalize in order to minimize the corruption. So now that you're in position, what's the sense that you're getting in terms of how difficult it's going to be to implement nationwide?
Yeah, I went through a digitalization process as a CEO of Qualimed before, and really it takes time. And this is an off-the-shelf system that we installed because there's a lot of customization, debugging, and shifting from one system to another entails a very strict project management process. So for PhilHealth, the bid that is going on is to really build the data from ground up. So it's not an off-the-shelf system. It's going to be built and customized according to the processes that currently are being practiced in PhilHealth. So I imagine it would take about a year and a half to do it. But right now, even with the legacy system, we should already do some changes, and especially for the claims adjudication and the turnaround time.
May pushback ba, Doc? Is there pushback from within in your plan to digitalize everything?
Not really. In fact, the people inside are very supportive. I think it's more if you may call it, the system architecture that needs to be thought of really in depth.
Okay. One last question. You mentioned earlier that last week you already met with some of the biggest top hospitals. I believe these are 8 private hospital groups. I just want to get a sense of how that meeting went, Dr. Mercado. Were they amenable to your suggestions? I believe Dr. Paragas mentioned in another interview that you were actually asking them to improve coverage and make healthcare more accessible, just primary care, more accessible to everyone, regardless of, I suppose, socioeconomic status.
Yes. Number one, I was asking them to help out, convince the doctor that every time we improve our benefit package and expand our support value, that the doctors really participate and also take out from their out-of-pocket professional fees the additional coverage that we are giving in terms of the expanded benefits. We don't have control of the professional fees of the doctors, except for some V package which are contracted out on a fixed basis. As regards the primary care, I really convinced the private group that it's worth looking at, and we will help them go up to a certain economies of scale. Because if you're only enrolling a few primary care patients or members, then it does not make any economic sense. But we're looking at institutional accounts which can be attributed or enrolled to them on a what we call batch enrollment basis.
Okay.
So this may include schools or state universities or corporations.
Yeah.
And I think they are heeding my call, and I think they will already take on the challenge of also putting up primary care clinics.
Right.